can we use digitization to augment community health systems, to improve the work of community health workers, access to services for rural communities? But the truth in most settings where these very complex digital systems are being rolled out is that community health workers are not paid, they're not supervised, they're not legitimized, they are not institutionalized. And so in an innovation setup where you're just testing it out in one place, it made sense. Yeah, can we leapfrog what's happening? But these systems have started to scale without question of whether the healthcare workers are being paid. And that sort of continuity without question is, I think, problematic.
Welcome to the Global Perspectives on Digital Health podcast with me, Shabdat Pardiai. This is the podcast that breaks you out of your bubble, giving you insights from people who are innovating or implementing with underserved communities around the world to help us take them back to our own work. I'm very excited to have our guest today, Associate Professor at Johns Hopkins University Center for Global Health, Smisha Agarwal. We are going to be getting some great insights across some of the challenges around monitoring and evaluation and around the fallout of the USAID cuts that we've seen globally in the last couple of months. This is going to be really, really great if you're in research and evidence of effectiveness of digital interventions, particularly for underserved communities. Let's get into it. It's going to be a good one. Smisha, it's so great to have you on the Global Perspectives on Digital Health podcast. Welcome. Let's start a little bit with a little bit about you and the work that you're doing at the Johns Hopkins Center for Global Health.
Great, thanks, Shubs. I'm excited to be here. So it is not an easy name, Johns Hopkins. Center for Global Digital Health Innovation. I direct the center. It is an interdisciplinary center focused on digital health that really brings together folks from different schools of Johns Hopkins, including the School of Public Health, Medicine, Nursing, Biomedical Engineering, and the School of Business. So it's really a place where we hope to advance digital health in a very interdisciplinary, cross-disciplinary way. Work is largely focused on, and I mean, it has evolved. I really started focusing on primary healthcare and on maternal and child health and chanced upon digital health. I should say that as an Indian, every second person I knew was an engineer. And so I'm an engineer by osmosis, sort of leaning in that direction. But I started accidentally in digital health when I was away from India for a few years to study overseas. And when I came back, I moved to a rural part of the country, saw that everybody, literate or with low literacy, was using phones actually to listen to cricket updates. And as a young and enthusiastic recent business graduate, I thought, well, let's see if we can use phones for healthcare. Right, because these are often places without access to clean drinking water, without access to electricity. And so that really became, and then this is now in 2008 when mHealth, the digital health, was not really a field quite as such, where we started a startup in our little part of Maharashtra to have community health workers monitor pregnancies and upload the data on a cloud where we can identify high-risk pregnancies digitally and respond to them. And so that was sort of my initiation. Since then, I have worked across sectors. I have been at Hopkins for a little over a decade, where we focus now on sort of broader issues of digital transformation, including the policy landscape, governance. We think a lot about effectiveness and impact, and really sort of, I think we're going to talk about this later, but really start with health first and what is a good allocation of resources as sort of a driving question rather than digital first, right? And so I think within any sort of healthcare context, that's sort of, and maybe that's sort of that's like our driving principle, and maybe what also sets us apart from other centers of innovation where, the sort of point of view is often we want to be innovative, but I think with our center, what we want to be is we want to drive healthcare impact. And if innovation gets in the way, then we want to remove the innovation and have it be innovation in service delivery or innovation in how we are thinking about it, not just tools and gadgets.
That resonates so much. We miss that and we breeze past let's get to the digital type of innovation. But innovation so much wider. That sounds really great and really, really interesting background, and great to learn about the work that you're doing at the center as well. Maybe before we get into an evaluation of impact, I think it would be great to just talk a little bit about the context that we're in at the moment. So we're in March 2025, and of course, we can't really talk about impact and evaluation without thinking about the impact that the current state of like the world, the current state of global health, and the impact that USAID and also other countries' aid cuts have had on the sector, both from just an impact on people and service delivery side of things, and also on the kind of the data aspects of that. Do you have, through the work that you're doing, the research that you're doing, people you've had partnerships with, do you have a view in terms of what you've seen or heard on what's going on globally?
When the stop work orders came out, I was in a remote part of India, in the state of Jharkhand, which is one of the states with one of the highest rates of infant mortality in the country globally. And we were working closely with TDH and the ministry there to evaluate and try to understand how frontline health workers can use clinical decision support tools to accurately diagnose and treat children presenting with fevers. And we spent a few days observing that. I'm very excited about what our research can help show. This was a piece of work that was actually funded through USAID, through their DIV mechanism. And I think it was one of the most robust pieces of work, because the interesting thing about DIV is that they really work collaboratively with research to iterate on the proposal.
Alluding to what DIV is, by the way?
I think it stands for Development Innovation Ventures. And so I think, unlike other sort of proposals where you submit a proposal and if you get funded, you execute it. In this case, we had worked with an army of economists at USAID to iteratively design and redesign the evaluation approach. And while it was an extremely tedious approach, it was also really helpful to come up with a proposal that's robust, and it had me walk away with thinking, this is how we should work in the space, right? Where we're acknowledging the reality, we're saying, how can we still take our research approach a notch higher? How can we realistically consider the risks actually of evaluating? And so I think what we had also done is we had looked at the evidence and it said, okay, here are sort of 3 concrete pieces of work that tell us that using such decision support tools can improve diagnosis and treatment of sick children. But they didn't demonstrate a significant impact because they were not large enough. And so can we actually use that to get to a right sample, right? So we really iterated on the details and I think got to what was a very robust proposal that would have really changed how the field is moving. And that was then interrupted, and since then it has been terminated. And of course, it's disappointing for us as the research collaborator, but it's far more disappointing for our partners who have spent 5-6 years building those community-based relationships, training the healthcare workers, gaining trust. That is not something you can earn back quickly. And I'm sure you've seen a lot of other narratives about more treatment and service delivery based initiatives for HIV, and where, of course, the situation very much will have, an impact on human lives, will cost human lives. But I suppose it was not just the termination of it, but also the abruptness of it, right, which was not planned. Because I think several of us in the field would agree that some things need to be fixed with the business of aid, right? A lot of things need to be fixed with the business of aid, but there is a responsible way to fix it.
Yeah. I guess it's that a recognition that things kind of need to change, but things can't change if also that abruptness has an impact on lives, infrastructure, and that more kind of intangible element, which is so important, like trust. I think shows the different layers of impact as well, that the negative impact that this has had.
And also that DIV was, they were doing some very responsible work, right? I can offer some critique for how USAID operated, but this particular engagement was exemplary. It's how others should actually model themselves after, right? Like sort of the iterative sort of development of how we approach evidence and how we are responsibly And I say that, I emphasize that because of the vilification of an entire group of people.
100%, yeah.
This was very extremely responsibly executed.
I think you've also then given us a nice segue into talking about the right approaches. So you've highlighted them through this example as well, actually. Even despite everything that's going on, this was an example of things being approached the right way. Monitoring and evaluation are kind of universally talked of as critical, but obviously really hard to get right. What's been your learnings? What can you share with us from the work that you've done?
Yeah, we've been supporting specifically for health programs, but also specifically for digital health programs. We've been a partner to implementing agencies to support implementation and evaluation, often to not just ask the question of does it work, but also to ask questions around when does it work well? How can you make it better? What must improve to make it work? Right. And so those are more implementation science questions of getting something to work. So it's not just a yay or nay, but it's also like a how. And I think my perspectives on it have changed. One of how we approach research traditionally, a lot of our practices come from pharmacoepidemiology, where we administer a drug and the patient takes the drug every day, and what that allows for is consistency of dose, right? But in health systems research, there isn't a consistent dose. There is high levels of variability because people and processes, governments, and so on are involved. And so I find that because of that, evaluation becomes very hard because actually we can't measure dose very well. And we're making a lot of assumptions. Often those assumptions are simply assumptions, right? Maybe the other challenge, and this comes back to this point of health first, is this idea of plausibility. If you want to see something works, it should theoretically make sense, right? It should make some sense. But the idea of plausibility is it's not based on logic, right? It's based on our prior beliefs, right? And so if somebody who is like an optimist, a technologist, might think something's plausible, and somebody maybe who's a little bit more pragmatic or has seen sort of community realities might think, no, that's implausible. And so I think what lands up happening is even our starting point, our question for where we should start is often implausible. Well, I think it's implausible. For example, if I send SMS messages to mothers about what they should eat and how they should conduct their healthcare during pregnancy, it would reduce maternal mortality, right? And there is some plausibility there, right? We can see sort of a theory of how that might evolve. But the context, which is often not considered, is, are there services that exist? Can the mother get to them? Do they have access to food? Like, do they have access to the types of behaviors that you're trying to change? And then if all that is happening, is the reason for mortality knowledge? Or is it just maybe preeclampsia? Mm-hmm. So I think there are a number of ways in which we can think it. But what I've learned over the years is that often our starting point, the question that we're asking and the impact we are expecting are incongruent. It doesn't.
And I guess the way I'm trying to see how that kind of fits together, if I'm a vendor or a founder in a digital health company, I've got maybe I'm in a different context. And in my context, it seems plausible from what my experience of life is, what I've seen to be available, and the privileges that I have within society and the infrastructure that I'm within. And so it's very easy then to think about how, okay, if we just did X, Y, and Z, it could be very plausible in another context. And so I guess what I take away with this is it might be, but you really, really need to understand the context first. And you might need to do a lot more work in challenging your assumptions. Is that what you're saying? Have I missed something?
I think the context, of course, is important. That's absolutely right. But I think we also need to just change our expectations of what's feasible with technology, right? Like chatbots, the new sort of love of the field. The truth is that the average chatbot people connect with for 15 seconds. Is that going to change vaccine beliefs? Can you imagine a 15-second chat will change a lifetime of long-held beliefs? I think that's not reasonable to expect. Yeah, sorry, unless you find ways to actually increase engagement. And for developers, what I recommend is just identify impact measures that's closer to where you're intervening. Right. And I think
close to where you're intervening and in your locus of control, I guess, as well. Right?
In your locus of control, as close to your locus of control. I think the challenge with that is often donors need to be educated to allow for that. And because they are really looking at lives impacted.
Absolutely. And I think that what strikes me then is that we have this trade-off, because ultimately we want to, within healthcare, you mentioned health first, right? We want to have an impact on clinical outcomes, but often they're several steps away from what we can affect in our direct locus of control. And so the contribution lines to them are a bit weaker, and there are multiple confounding variables that also then impact the success of those clinical outcomes. I definitely see across many contexts, not just in underserved or rural contexts, it's really, really hard to kind of make the leap to then the bigger clinical outcomes that everybody wants. And so maybe we want these health economic outcomes, maybe we want these clinical outcomes, but they're harder to move the needle on. It takes time to get to those. So how does that fit in kind of what you're saying?
Yeah, I guess, and maybe this is an overgeneralization, but I think our hypothesis going in is that digitization or digitalization will achieve outcomes that are superior to a non-digitized approach. I think that hypothesis is often not the right one to start with. I think we can establish non-inferiority, right? And I think part of it is also like the media. When ChatGPT and the LLM-based models came, so did the studies saying that LLM sort of was, patients had greater satisfaction with LLM-based triage than with real doctors. But they were not necessarily comparable, because we're not talking about disease acuity. We're talking about sort of very early triage where patients are not presenting with anything that's quite significant. And so, but that sort of made the headlines. And then to a lay, a person, that's like, great, like ChatGPT can take care of my healthcare, right? And that sort of started making the rounds, a future without doctors. I think we really, for that reason, there's a space for innovation, and there is a need for pragmatism, because I think with some work, ChatGPT could work in clinical settings, but we really have to define the boundaries of it. In what setting can we actually use it, and so on. We have to define that.
I mean, the use case and the tasks, right? And other language models are available as well. I guess if this was the BBC, they'd be like, "Oh, we don't want to just talk about one brand." So.
Right? Sorry. Yeah, absolutely.
I'm only trying to be funny. So really understanding the use case and the context, really defining the task that you're trying to help within that context, and then defining the direct kind of benefits. Of course, then you can talk about the second and third order effects of the other things that we want to get to, but with a degree of humility and pragmatism, I guess, and not jumping to the conclusions that often hype lends us to doing sometimes, right?
Often, I think the right outcomes are not actually better healthcare. It's often in the area of like efficiency and long-term gains to the health system. Those are harder to measure, so we don't look at them. There are challenges, let alone the upfront costs of that heavy infrastructure. And so one thought is just thinking through what is the context within which that makes sense.
That touches on what you mentioned earlier, health first, because that's a type of impact, and perhaps the most important one. Kind of working backwards from, okay, here are the healthcare goals that we want to achieve. Therefore, what needs to happen to make that occur? And then identifying which types of innovation might serve them. One of them being digital interventions, but others, like you alluded to, are service design or reshaping a process or doing some, having people working in a different way. That's also innovative, right? And we always jump to the bells and whistles of digital. And so I think, but the post I'd seen earlier today was, an initiative that had been developed in Brazil for community health workers, supporting people who had problems with access to healthcare. I can share it in the show notes. And the learnings from that were taken by a council in London and implemented and supported community health workers to go and then do outreach to people who were struggling to access care in the community, and resulted in actual tangible clinical outcomes, vaccination uptake rates, other really, really beneficial impacts. And I was like, this is a great example of innovation, but no one talks about it as innovation because there was no AI involved or digital health involved. And so you mentioned this at the beginning, and I just wanted to touch on that, because if we think about health first, then you're thinking more broadly about what you want to do. And then you've understood by talking to patients and the people who are delivering care around what they're struggling with. Then you're open to which solutions, and then you're working with them on, like, here are the ones that technology could help with. And so can you elaborate on health first? Have I got that right? Do you see it in a different way?
No, I think that's exactly right. As a center that focuses on digital health, we often have folks come to us and saying, hey, here's an innovation grant. You're the Center for Innovation. We want to do something innovative. Give us an idea in digital. And I think my sort of concern often is that the starting point is I want to be innovative so I can be competitive in this ecosystem. And we need to flip that. And I think it's harder to flip that in the global ecosystem because we're not close to global communities where we are working often. And so the challenges are not as straightforward to us. We're also 2 steps removed from the idea of plausibility because we don't see the reality. And so I think that often lands up being a challenge. But I sort of, that's really it, that identifying what is the challenge and if digital AI-based intervention makes sense. I think from an innovation lens, in smaller settings, test settings, it's okay to try innovations, right? Because we do have to have some blue sky thinking. We do have to think about ways that may seem implausible, but we're like, yes, it might be possible. Like, we've certainly seen that in our lifetime. But there's a balance to be had there, because often that sort of blue sky thinking then becomes the norm and we stop questioning it. And one of those examples is, can we use digitization to augment community health systems, right? To really bring improve the work of community health workers, make it easier, have access to services for community members that are in rural communities, have greater continuity of care, referral, and so on. But the truth in most settings where these very complex digital systems are being rolled out is that community health workers are not paid, they're not supervised, they're not legitimized, they are not institutionalized. And so in an innovation setup where you're just testing it out in one place, it made sense. Yeah, can we leapfrog what's happening? But these systems have started to scale without question of whether the healthcare workers are being paid. And that sort of continuity without question is, I think, problematic.
And thinking beyond just the intervention related parts of success and leading to like overall like societal benefit, it's thinking about the layers around that, right? So certain kind of people related, process related, or like political policy related determinants of success as well, I think. And so I think you've highlighted this. I think Ruchit, when I talked to him, who is one of the founders of Cushy Baby, talked a lot about the insights they had got from working with community health workers, where they had deployed in India, in India as well. And what you've said also chimes a lot with the work that the Community Health Impact Coalition advocate for very successfully. So I think we don't appreciate the importance of these kind of things in determining success. So all the funding goes into the tech part of it and nothing goes to like the people part of it. And I mean, even with the USAID cuts, I guess a lot of the data infrastructure or the things that have been successful have relied on also people engaging with them. And some, even with funding from USAID, are still not getting paid.
Yeah, I actually, in the last month, also spent some time where Kushi Baby works in Rajasthan. And of course, the work is incredible. Sort of another complexity in the community health worker ecosystem is that they have too many apps. They have an app for everything.
Yeah.
They're just re-entering the same data over and over. But where they see value is simple. They see value in knowing what they'll get paid digitally, having that accountability. I've offered X services. It's performance-based financing. So I will get Y amount in my bank account this month. And because of that, that's sort of their hook to say, okay, I will use the app that allows me to have visibility into my payment. So I think that's maybe just in terms of a very clear logic model there, right? Very clear, like, here's the intervention, here's the benefit. The community health workers use it. There's accountability. And I think financial accountability is maybe one of the clearest sort of impact metrics, right? It also reduces waste, improves efficiency of system. And governments need to come in to actually help solve for and create an environment that allows for several of the problems that you've identified, including salaries, because USAID and external entities might push for certain community health worker salaries. But I think the other perspective, and I say as a former healthcare worker from India, you can't, and this is one of the issues, you can't push for community health worker salaries that are higher than midwives and nurses and doctors in the country. That's sort of the sort of
it's part of the context, right? Yeah, it's the complexity.
It has to be part of the context.
Yeah. So we've talked about some of the kind of policy related things. When we kind of started this kind of bit of the discussion point, particularly on impact evaluation, when we started, and we were talking about a good approach. And I kind of want to also think about this from a researcher or a vendor who's trying to evaluate their intervention or their tool lens as well. And thinking about, look, I'm trying to do this in the right way. I want to measure the right things. I want to engage with people and partner with them in the right way. How do I set solid endpoints that are within my locus of control? Also on the health economic side of things, it sounded like you'd got somewhere with like robustness there. So if there's anything you can share on either of those, that would be great.
Again, for developers, implementers, again, the ecosystem is in some ways led by donors, and so they have to be responsive to it. And there's often a mismatch between what one is able to prove and what is realistic. And so let's say that what one needs to establish to sell are vanity metrics. And I won't speak about that, but that is required, right? Like that's needed. And so that might be, let's say if you have a chatbot intervention, you get 20 million views on a Meta platform, right? And of the 20 million, 1,000 people chatted with your chatbot. Maybe 10 people chatted with your chatbot for more than 15 seconds. And so within those 10 people out of your 20 million, you are sort of able to say impact. So that's sort of the tricky thing about impact. So I would say that I think it's really important to be very concrete about what you can realistically achieve, to have sort of the outcomes proximal to where you're intervening, to consider the context. I think thinking about university partnerships often is a great idea because especially in the innovation space, implementers don't have to find the funding for evaluations themselves. A lot of universities would be thrilled to partner with them and look for alternate sources of financing. Or they may have university sources of financing. But finding ways to integrate with researchers, with local and global research entities is a great approach. It allows the implementers to focus on the implementation, and it allows somebody who specializes in it to think about the evaluation.
And it is in the context.
As in the context,
And you touched on another thing. I know you didn't want to go so much into vanity metrics, but it links to what you mentioned earlier, especially for donors and what they need as well, around does it work, yes or no, versus also how do I continuously get better? And so I feel like there's a call to action to the donor community of like also understanding contexts and be feeling more real. And it's easy for me to pontificate on this and not being a donor or kind of fully getting their context. Note to self, get a donor on the show. But I think there is this, it's really hard, right? Because there is a lot of value to, okay, this funnel that you talked about, 20 million views 1,000 interacted for 15 seconds, which led to like maybe a change in something for what one person. You got the vanishing metric, maybe that answered a yes or no question. But then when you look at the actual impact, it was very low. But again, that it's a process, right? So you could look at that as a failure, right? Or you could say, what can we learn about that? Why was this conversion so low? What do we need to understand about this context? And so the conversation becomes less, I need to hit this number to get the next round of funding, to here's what we've learned, here's what we know that will now give us the depth to get into this and have an impact in this community and in this context much more meaningfully. What needs to happen there?
Does this work or not? The scientific community, I think, has done a disservice, right, to sort of guiding policymaking, because we're fixated on our significance value, 0.05, and which is a clear yay or nay. And for some decisions, that's critical. I think for health systems interventions, we need to take a different lens. I like sort of the analogy to how we think about a business spreadsheet, right? When we're doing sales projections, we have a set of assumptions, and based on assumptions, we make our best, we decide a strategy. Based on the numbers, we're still being evidence-driven. We're not being binary in our consideration. We're still being evidence-driven, and we're making some assumptions to make a decision. Because the truth is, donors need to make a decision, right? Like policymakers need to make a decision, go or no go. And if there is no evidence, they still need to make a decision. And digitization is happening, whether or not we like it, right? Innovation is moving forward, whether or not it makes sense or is plausible. And folks that are policymakers, like including governments, right? Like they're being asked, what do we do with AI? Let's do something AI. If you're not doing AI, you're doing something wrong. You're not sort of tapping into the new world and you must, right? And so there is this sort of fear of missing out of the new world. And so I think, but what is a good approach is, let's look at the evidence critically and then make a best informed decision. The sort of fixation on numbers and numbers alone often misses out on the right approach and question. Because I think the right approach or question is not whether or not it's working. It's just, the world is evolving. Some approaches are moving forward. How do we get them to work better, right? And so, for example, in a space of misinformation, disinformation, 15-second conversations or 2-hour conversations, people are accessing information online. How do we support the right types of engagement? How do we create sort of new engaging strategies? So I think that's maybe those are some of the right questions, I think, to a good starting point. And by simply going yay or nay, we're actually missing out on the opportunity to just get better, improve things. Because even if we say nay, like I can show that something's not working, and yet the community is going to continue investing in it, right? Because there is a lot of enthusiasm for this space. And so...
And even the other side, right? Something might look good in terms of numbers, like that yes or no number that you wanted, i.e. could be a vanity metric. But actually, in terms of making a difference for someone on the ground, maybe it didn't do. So I guess it can work the other way as well, right? So how do we dig into that? So yeah, totally. I could talk to you about this for hours. That's so interesting. So we've got some tangible takeaways, both from a policy perspective and from a kind of vendor or researcher perspective as well, to try and really think about, I think what I've taken away is like, what is in my locus of control? Thinking about working, I think another takeaway, work with universities, have university partnerships locally to where you are. They're a great resource to A, understand the context, B, have the kind of methodologies that are appropriate for that setting as well. Yeah, and
as a university professor, that's my totally unbiased recommendation.
Totally. Yeah. And then I think the third one is that when you're thinking about system change, using that yay or nay approach, you might need to think about that in a more nuanced way. Okay.
That's a great summary.
Thank you. Yeah. No, there's lots. There's so much more, but those are the things that have stood out to me. And then I wanted to. So you've also been instrumental in creating the Oxford Open Journal. Are you able to tell us a little bit about that?
Yeah, I would love to. I think that has been maybe one of the most delightful parts of my professional. There is, just like aid, there is a lot that's wrong about international publishing in the healthcare sector. I have just been really grateful to have the leadership at the Oxford Open Digital Health Journal, because we're asking questions that feel like they haven't been asked for for decades of publishing. It doesn't mean we are answering those questions or we are even addressing the issues, but at least we're asking some of the right questions and we are taking small steps to move towards it. And so it is a journal that's focused on digital health. We've approached it very differently. We have, because it's focused on LMICs, we have a very globally representative editorial board. We've taken active steps to ensure that we also have a globally representative pool of reviewers. So it's not just US and UK based reviewers. Mm-hmm. I think the question that I found myself asking and that I had to negotiate, because Oxford Publishing House has been around for several decades, that why are we forcing Spanish speaking authors to write in English and then their materials inaccessible to people in their countries, right? And why are we not asking more of these questions? It's really nonsensical because, I mean, for countries, this is maybe a total side comment, but for countries that have been colonized, we know that English language is basically a tool of colonization. When people don't communicate in a language that they're familiar with, they really can't communicate how effective or creative or intelligent they are. Right. And so I think in scientific discourse, that's really critical that people are able to communicate in a language. Like I learned science in English, and even though Hindi is my mother tongue, I would not be able to communicate any science in Hindi. Right. So it is actually really important that you're able to communicate science in the language that you use to it. So, and we're taking little steps to address all of those little challenges, right? We're asking those folks that are funding supplements to make sure that at least abstracts are available in the language where the work is done. We are requiring some of this. We are creating, to the extent possible, with my dual hat of Hopkins and the editor, have training and writing workshops accessible to LMIC authors who don't have maybe as much sort of ease of access to such opportunities. And so, so lots of like exciting things going on that side of publishing, at least starting with, again, asking the right question. And we're just excited because it is a very practical and applied journal that is really drawing on insights from a lot of policymakers and folks who are implementing large scale digital programs.
I mean, I think massively needed. When we've talked before, you've talked about the little things that we can do in our ecosystem, each of us, to improve things, right? And even more so now, given everything that's happened, because obviously the USAID cuts have happened. Do you have any other insights to share or other parts of the ecosystem you think that need to make small changes?
I think maybe if there is a silver lining to recent events, it is that it has allowed a lot of people to voice their concerns, right? And I think for a lot of, and I say this to my students, we want to question the status quo. We should be questioning the status quo because we are brought into a system of aid and of global development that has stopped questioning how things were done. And the world has progressed, but our field hasn't progressed. And so I don't think the answers are always straightforward, right? We're in deeply entrenched policy systems that have worked in the same way. And people intend well, like that's at the core of it, right? Like the field as a whole is full of humanistic individuals who want to create value in the world. And so one is even more nervous to like call something out because you don't want to be calling out the intention of your peers. So I think we have to find ways to have these difficult conversations where we are actually able to call out the power dynamics, call out the imbalances that we see around us, and really just question the way that at least I think maybe the summary of all of this is like, let's just start with asking the right question, right? We don't have to have the answers. I think the answers are often complex. They are contextual, they are ever changing, but we should at least prod on with good questions.
And for you, it's really well articulated, by the way. For you, what is the key question that we can take the time to answer now, or we have the opportunity to answer now?
I don't know if there is one question. I mean, we've talked about a number of issues here. Impact, where often I start with like, is it plausible? Like, right. And maybe if I was more optimistic, would it be plausible? And in the aid space, I pause often with my discomfort because I find myself being uncomfortable in a lot of settings where, because of my experiences, growing up in India, and previously where I didn't voice that discomfort. I think now I try to voice it more, because I think those are good questions to ask, right? If something doesn't feel right, chances are it isn't, and it's at least worth a discussion.
And I think, if it wasn't for the abrupt nature of this, I guess the abrupt nature of this has shifted everyone into kind of survival mode and thinking about what things, almost like triaging, and like what can survive, what can we salvage, etc. And at some point, we can start having the headspace then, right, to have this type of conversation. And so how can we make sure that things are really partnerships, addressing the power dynamics? How do we make sure that leadership is local? And I think, you talked about silver lining, and hopefully enough stuff can survive that we can ask those questions in the wake of this, right?
Absolutely.
You put that really well. I think, and just linking it to this kind of the bigger picture around the open access journal, because some of this propagates into like academia and the problems with academia, etc., that you're really trying to address. But I think
academia is perfect.
Yes or no question, right? And I mean, other ways this manifests, right, is like, for example, those people who then would benefit from Oxford Open Journal would be able to publish, right? And then, I don't know, they'd be able to have the opportunity to go and present their work somewhere, except they can't get a visa to go there. And so that's been playing out for years. And one of the things that I saw in the community was that, for example, the Global Digital Health Forum that happened in Nairobi for the first time. And so I was kind of like referring to like this, these are really good examples of small changes that when they stack up can be quite meaningful for people actually being at the table because of the expertise that they have within their context, and making sure that that is represented on the global stage, I think is really important.
Yeah, absolutely.
Great. Okay, let's mention the Global Digital Health Forum. Is there another one this year? Is there a plan? Do you know anything about whether another one is planned?
Not sure. Depends, yeah. It was supported by USA, but Geneva Digital Health Day is coming up, and
yes,
I think I haven't been to one, but appreciate that it brings a diversity of voices, and not the same old sort of old folks that have been around the block for the last 2 decades. So that's something to look forward to.
Yeah, absolutely. And the Geneva Digital Health Day, just to, I guess, like give that a shout out, is so Smisha, you'll be attending. I'm also going to be attending as well. I'm planning a panel around something around that we talked about, which is like, how do we as a ecosystem, as an industry, think about failure differently in this kind of continuous improvement and share systemically things that have not worked, and maybe someone's going through the same problem and therefore can like, that's valuable, right? And so if we think out of that yes or no, black or white, failure, success thinking, we can all learn more. So and then Geneva Digital Health Day is a great opportunity to meet people and talk to people, vendors, policymakers, researchers who are kind of working and implementing from a much more global perspective, particularly in LMICs are well represented. So if you're looking for a conference that really brings people together in this space, it's a really good one.
Fully agree. There are others also coming up. I think, I don't know the exact dates, but Helena has their annual conference. I think that's happening in Botswana this year.
Okay. Tell us more about that one. What's that?
Helena is focused on health informatics and digital health. Well, the conference happens, I think, every 2 years, but it really brings together the African diaspora. And then Africa Health Tech Summit will happen end of August, which is in Rwanda, in Kigali. And that has been happening for the last few years, really brings together private sector. And policymakers, and sort of helps push some of the conversations around public-private partnerships and privatization of healthcare sector, amongst much else. So, so there are a few interesting, I think, digital-focused opportunities to gather outside of the Digital Health Forum.
Awesome. Smisha, it's been so valuable and insightful talking to you. We really got some real talk as well. So really appreciate that instead of like just kind of esoteric sound bites. It's great to kind of get a real understanding of some of the challenges in the field, not just kind of sugarcoating things. So I think that was really valuable and insightful. So I'm really grateful for your time.
This was really fun, and look forward to many more such conversations. Great.